Hi, everyone. Thanks so much for joining. Just a reminder, friendly reminder, that if you can, please put your cameras on out of respect to our speaker. I also think today will be a little bit more interactive, so hopefully we'll all get to see each other here. Um, I'm going to go ahead and introduce our speaker while we start to have a couple more folks joining us. She really needs no introduction. Dr. Wanda Pratt is a professor and the Associate Dean for Inclusion, Diversity, Equity, Access, and Sovereignty Ideas in this information school with an adjunct appointment in biomedical informatics and medical education and the medical school at the University of Washington. She received her PhD in medical informatics from Stanford University, her MS in computer science from the University of Texas, and her BS in electrical engineering from the University of Kansas. Her research focuses on both understanding the work people do to manage their health, as well as designing new technologies to support that work and reduce its burden. She has worked with hospitalized patients, as well as people coping with a variety of chronic conditions, such as cancer, diabetes, asthma, and heart disease. Her recent work focuses on support for people from historically marginalized or underestimated communities. Dr. Pratt has received Best Paper Awards from the American Medical Informatics Association, the ACM Chi Conference, the ACM Conference on Computer-Supported Cooperative Work, and the Journal of the American Society of Information Science and Technology. Her research has been funded by the National Science Foundation, the National Institutes of Health, the Agency for Healthcare Research and Quality, and the Robert Wood Johnson Foundation, and also other places, including Intel, Google, and Microsoft. Dr. Pratt is a fellow of the American College of Medical Informatics, and she recently served 2 terms on the board of directors for AMIA and chaired their 2018 annual symposium. We're so delighted to have Dr. Pratt join us. Thank you so much.
Thank you for that great introduction, Pooja. And it's wonderful to see so many faces, a lot of them familiar, which is very nice. I'm going to share my screen now and start my PowerPoint. And since Pooja introduced me, a lot of this has already been covered, but letting you know that today I'm going to talk about a particular project called Patients as Safeguards and how we were designing technologies to support patients. Pooja's already covered a lot of this. Maybe the one thing is that my first job out of undergrad was working at NASA as a software engineer, prescribing exercise for the astronauts to prevent deconditioning in space. And I got to test out exercise equipment on the Wilmot Comet. So you can ask me about that sometime if you're interested. Also, I just wanted to point out that I'm really bridging 2 communities, very much active in AMIA, as you all know, but also really active in the ACM SIG-Chi community, the human-computer interaction community. So as you'll see in the talk today, a lot of my work is really design focused and connecting to a lot of that community as well. Now, I think it's most motivating to start with a story to help people engage and understand. And here I want to flag that I would love to have some interaction at the end. So I want you, as I tell the story, to think about what are some places where things went wrong? What are some places where the patient lacked power in these situations and that power could have helped? So think about that as I go through the story, and then we'll ask for either people to unmute or chime in for the chat too. So here, this is a story about John. So John has been having some unusual symptoms for a few weeks. High fever, weird pain, definitely different than anything he's had before. And it starts to get worse. He goes to the drugstore and takes his blood pressure and notices it's really low. And his wife encourages him to go to urgent care. So the 2 of them go to urgent care. And even though he's been to urgent care before, in the emergency room and several doctor's visits, this doctor spends a lot of time with John and asks a lot of detailed questions. John is living on the West Coast. But the doctor uncovers that John has recently traveled to Vermont, and she suspects that John might have Lyme disease given the unusual nature of a lot of his symptoms. Now, note that unlike where you are in New York City, Lyme is pretty uncommon on the West Coast. So the clinicians are not as used to thinking about that as a particular explanation. Um, but she's listened to John's heart and is a little concerned and connects him up to an EKG to see what's going on. And she discovers that actually he's an AFib and his heart rate is very low. And the EKG shows that he has a second degree AV block. So she says, okay, the urgent care, we're not equipped to deal with this. You really need to go to the emergency room right away. And tell them that I suspect Lyme disease and have them do a blood test for that. But you need to head there right away. So John and his wife head to the emergency room, the emergency department, and they take him very seriously. They react quickly, trying to figure out what's going on, do another EKG, and go away for a while. And then after a while, someone, they are not sure who this person is, shows up with a pill in a white paper cup. And well, actually, first, before that happens, the wife suggests that they do a blood test for Lyme, saying that that's what the other clinician suspected. The emergency room refuses to do that, saying that they can't follow up on a blood test for Lyme disease. It takes a while for those test results to come back. Just go see your primary care doctor to get that blood test result. Even though John's wife protested and wanted to get this test started right away, they refused to let that happen. Then someone shows up with a pill and just says, here, take this pill. John's wife complains and says, wait a second, what is this pill that you're giving him? And the person says it's metoprolol. He needs to take this right away. And John's wife says, wait a second, what is metoprolol? And the person says, oh, it's a beta blocker. He needs to take this right away. And John's wife says, wait a second, beta blockers, don't they slow your heart rate? His heart rate was 42. It was below 50. Are you sure it's okay to take a beta blocker? And at this point, the person is getting very angry and very upset, as John has to take this medicine right now, or he risks having a stroke. So John takes the medicine and they send him home. Unfortunately, they later discovered that metoprolol is contraindicated for when the heart rate is less than 45 beats per minute, which John's clearly was, at least at the urgent care. It's also contraindicated for when there's a second or third degree heart block, which John also had. Now, John later completely crashes, and in the middle of the night, John's wife has to call an ambulance, and the emergency technicians show up, and they can't even get a blood pressure on him. He's in such bad shape. They're trying to revive him, giving lots of stimulants, and bring him into the hospital where he spends the next week in cardiac intensive care. It turns out he did have Lyme disease and he did fully recover, but some of these problems, I think, could have been prevented. So I would love to hear from you, from this story. What did you see as what kind of went wrong here? What could have been improved? Where did the patient lack power, the patient or their caregiver? Go ahead and unmute and speak up, or chat, either way.
Dr. Pratt, it's Adrian. I found it striking how the patients are just told, just trust us, do what we're saying, just trust us, and not given information needed to make an informed decision or even veto the suggestions of the providers.
Yeah, great. So clearly disempowering the patient in some ways there, not giving them information, not listening to them. Great. Other points?
Yeah, I mean, I'll add, it was almost at each stage, right? They had questions and they were questioning things. And this particular patient and his wife were actually quite well informed, and yet still, ignored. Whereas, even if a patient isn't well informed and has questions, shouldn't be ignored. But it's to me, it's quite scary to see that even with the well articulated questions, if you will, around, is this the right medication? Does this make sense in the context of what's already been determined? That I have that's still not enough to, bring pause to kind of the plan that's already in course. Because I think we just see that there's just such great, unfortunately, potential for things to go wrong, and so many patients that might not be able to even, articulate those, those worries.
Yeah, excellent point. And I think I'll use that opportunity to disclose now that this was my husband. This was my husband, and this was me. And this was after I wrote a grant on patients as safeguards to reduce these kinds of medical errors. So yes, even people who are incredibly well informed and connected and really understand the healthcare system, it still can cause problems. Yeah. And I see in the chat, Kayla says lack of continuity of care. Yeah, I think that's a good point, right? From the urgent care to the emergency department, we still have issues with interoperability. And maybe when John got to the emergency department, the EKG no longer showed an AV block. It clearly did still show atrial fibrillation, but more commonly that's associated with a higher heart rate and a risk of stroke, of course. And not giving the blood test, right, not respecting their wishes and trying to get things done. I will say in the details, not having that blood test definitely slowed things down, because even when John was admitted to the cardiac intensive care unit, they still didn't believe he had Lyme. And and so it took extra time for them to do the test, only when I absolutely insisted, and took another day to get the results back. And that changed his course of treatment, of course, too. So other things you see here.
I'll just jump in for a second. It's just so, I think, interesting how much of it is on a sort of a personal decision of the providers. It seemed that things were going on the right track, right? Somebody suspected Lyme disease. There was the right trajectory established, and it got completely derailed when transition happened to a new place. And it's like, there's no, I agree with Kayla, there's no continuity, and there's no like intellectual continuity, that some of the ideas that were developed got completely dropped and never pursued further.
Yes, yeah, exactly. And honestly, I've hung out with people enough to understand that there can be this hierarchy too. And sometimes clinicians who are in the urgent care are not considered as high up in the hierarchy or as respected as those that are in the emergency department. And I think sometimes that can play a role. Chenhua pointed out, yes, it is problematic that they don't welcome questions from the patient's family. I clearly was being quite assertive, and it's hard to do that. Even I don't have a PhD in medical informatics. I do work in patient safety, and it was really hard to do. And yeah, but yet still not listened to.
Can I add one thing? One thing I noticed was that you mentioned the long pause between arriving at the emergency department and you've got your intake, and then there's this period of time where you don't know what's happening. And so not only is it kind of, you're at the whim of other people who may assume that you know what's going on behind the scenes, given what your situation is, but there's that complete lack of contextualization, I guess, from the patient side, because you don't have the same information that the clinicians who are treating you do. So you don't know that, oh yeah, it's supposed to take this long because they're actually doing this amount of work behind the scenes. And so when there's no one really informing you of that, that adds undue stress as well. And I mean, I was recently in the ER myself, and you just kind of sit there and you're like, what's going on? I have no idea. And so it adds to this, additional undue stress that might not be, altering the course of treatment, but definitely, imbues a lack of trust in the process, because it's just a complete lack of transparency. Even if you do have someone who finally comes back and is very patient and, great about explaining, okay, this is what we're going to do. Here's your treatment. Oh, thank you for your input. Like that lack of time, or that lack of interaction for such a long period of time, is very stressful.
Yeah, indeed. Yeah. And
Wanda,
go ahead.
if I could just ask, Ms. Herb Chase, did you say that you found out that the metoprolol was contraindicated and said that to them?
Yes.
Right. I mean, the Lyme disease, it's a long-term therapy. The fact that they gave him the medicine that was exactly the opposite to what he needed is actually the most disturbing aspect of this for me. And you told them, yeah, I'm not sure you could have done much more than that. You actually said, this is you could have refused the pill. But that's not obviously the optimal workflow.
Yeah, there are clearly challenges there. And yeah.
Wanda, this is Rita. Hi.
Hi.
I'm curious though, because I unfortunately have had my own experience with Lyme disease in my family, and it was horrific all the way through, a long journey. But I'm wondering how the lack of knowledge contributed to that, because Lyme disease under the best circumstances is so often mistreated and not identified. I'm wondering, in the interaction that you described, to the extent to which this lack of familiarity with Lyme disease, and even, I'm sure you're aware if you've gone through it, there's a lot of controversy around whether it could even cause those symptoms. And I'm wondering the extent to which this lack of awareness, and maybe lack of, it's even more than awareness, it's this weird disease that some people don't think exists. So I'm wondering how that entered into the interaction.
Oh, I think you have a great point, Rita. I think the denial of chronic Lyme is a key part here of why they refuse the blood test, right? I mean, I don't know, right? But I assume that was part of it. They don't want to deal with someone who's complaining about something and trying to find an explanation that they don't think is a valid explanation for that. That's my interpretation. I don't think we'll ever really know. We did file with the official patient, I can't remember even what the name of the office was now, but we filed an official complaint, which amazingly, despite the fact that I had collaborations with that hospital, wasn't followed up on either. And I had to send repeated messages to even get an acknowledgement that they got our message. So it's hard to know what was exactly going on in people's mind. I do think there is also, in addition to this denial of chronic Lyme, is this notion on the West Coast that Lyme is just not as familiar to people. But come on, people travel to the East Coast all the time. This is something people need to be aware of.
Yeah. So my further, I won't spend too much time, but I do think it might really impact what happened. When I first was trying to find treatment for Lyme, and I actually had to leave the country to get treated for Lyme, it was my daughter. We call the head of infectious disease, who specializes in Lyme according to the bio on the website. And I was informed that she doesn't treat Lyme unless it's acute. So even on the East Coast, where presumably that's where it all, which is false, where it all seems to happen, Lyme specialists don't treat Lyme disease.
Yeah. There are a lot of challenges that kind of are brought up from
Yeah.
here. And someone asked, what year was this? And hopefully it's in the past. This was in 2015, so it was a while ago, but I can tell you this is not in the past. Even since this time, I didn't include this slide, but my family has unfortunately had many medical errors, and some as recently as a year ago. So I don't think this problem has gone away. It's still a big challenge. I'm going to go on so that I can cover some of the rest of my talk. I really appreciate everybody being so engaged here too. So the notion of medical errors and patient safety has been highlighted, and I'm sure all of you are very well aware of this, but it's recently come back up in the press and received a little more attention. This was a headline from the Wall Street Journal just last week. I think that was spurred by David Bates and others' report from their analysis of Harvard and the surrounding connected medical centers, where they showed even recently 25% of hospital admissions result in an adverse event, and there are 7% of all admissions have preventable adverse events. So this is still a major problem, quite clearly, even with recent data. And if we think about what is the problem, you know, when you talk to everyday people who aren't in the field like we are, often it comes up, there's a bad apple, right? That person who gave John the pill, we don't even know who that person was. Was it a nurse? Was it a doctor? Was it a med tech? We actually don't know because there's no information for that. But it was, that person is a bad apple. That could be an interpretation. But we know that that's a wrong-headed approach, right? People don't want to make mistakes or errors, and they don't want to be bad at their job, but there are systemic effects that really make it hard to carry out medical work. This is a figure probably that you've seen. I've adapted it from James Reason's book on human error, and it talks about how in any kind of a complex system, there are hazards that can lead to losses. And because there are humans in the loop, of course, there are places where things can slip through the cracks or the holes of this Swiss cheese model. And the goal is to put in place as many pieces of Swiss cheese as you can to try and reduce the probability that things are going to actually result in a loss or a harm. And there's been tons of work in patient safety. A lot of work has been done at Columbia on this space too, like Sarah has done a ton of that space. But there are things like surgical checklists, medication barcodes, improved handoffs, all of which were implemented at Harvard before this recent report. And there's still problems. The point of my project and that I want to make is that what's been less studied and less supported is really recognizing patients and their caregivers as potential part of the safety process and really potential safeguards as this whole medical error reduction process. So I just wanted to flash up an acknowledgement. This is a big project with a lot of collaborators, a couple of physicians who are collaborating with me, and a lot of PhD students and master's students who helped with this work. It was done at both Virginia Mason Hospital and Seattle Children's Hospital. So also looking at pediatric population and funded by AHRQ. Now, we're not the only ones to take this approach, and especially a lot of work has been done at Columbia on some of these issues, really looking at ways to help patients in the hospital and their caregivers get information from different kinds of information displays. Lauren Wilcox, David Vaudry, and collaborators, different ways to explain the content to people. The Open Notes Project is a great effort along these lines, starting in outpatient, but now there's more on the inpatient side too. Lisa Grossman-Liu and others really looked at different acute care portals and how that is supported. But our approach is really focusing on the design aspects of this. really taking a human-centered design approach, including, interviews and observations, co-designing with patients and caregivers, and then prototyping and creating what we call technology probes, which is kind of minimally functional prototypes that could be deployed in a very kind of experimental real world setting to learn more about what works and what doesn't. And I really like to approach this co-design process because I see that it accomplishes many things. It helps share control of the process with people. It helps everyone share their own expertise. Everyone has lived experiences, from the clinicians, the nurses, the physicians, and then med techs, as well as the patients and their caregivers. It also helps to motivate change and to enable learning from each other. I've also found that this co-design adds a unique component to really understanding the problem. I found that what people say results in understanding a certain set of things. What people do helps us learn another somewhat overlapping set. And then what people make in this co-design process lets us learn even more. And that's what I found in this project. So I'm going to share a few samples of some findings to let you know what we found in this project, co-designing with patients and their caregivers. So based on some of our observations and interviews, we really found that there's a very poor patient information environment in the hospital and emergency room setting, that people have trouble receiving information. Often it's in verbal form, it's unscheduled, it comes in unexpected times. Maybe when somebody is just recovering from anesthesia, it's hard to process that information. There's no other way to get it. People had trouble keeping track of what's happening to them and their own symptoms when clinicians would come in and ask them. And people had trouble communicating, just like John and I did. When there are problems that are coming up, who do we talk to? How do we know who we're talking to and who has the expertise to be able to deal with the information that we're providing? An example of that is a caregiver of a pediatric patient. They said, we spent a lot of time sitting around waiting for the doctors. Then we would go to the bathroom or to get food and come back, and they would have been there without speaking with any of us. We would have to wait another day to ask our questions or share information or observations. To address this problem, the participants in our study looked at the problem of being trapped waiting for doctors and unprepared for information exchange. And they built their insights on a system that's available in the Seattle area, but I think it's also available in a few other cities around the country. It's called One Bus Away, and it basically shows you when to expect your bus to come. So it can tell you that, these are the buses that have been there before. Is the bus that you're waiting for delayed? Help you make decisions of when to leave to catch the bus. So these participants designed a system that they called One Dock Away, that was for rounds and for other kinds of visits from their clinical care team. And they envisioned to have a view of a roster of the care team and planned people who were going to come see the patient for that day's rounds. And they envisioned something like a phone app to let them know not necessarily what other patients were actually being seen, because you can't share that information, but maybe even having a sense of, am I third on the list? Am I next on the list? Am I the 20th person on the list? And I can go to the bathroom or go get some food before I can expect them to come. Another challenge was receiving the information. And just like in John's situation of not knowing who the people are and what their role is. And caregivers often talked about challenges, especially for pediatric patients, of when they're not in the room overnight or when they have to be away from their loved one, not knowing who's been in the room over time. So participants created this design called an identitron, and note that they had a bit of a sense of humor with Dennis Breve and Peggy Fixit as their participants here. And the idea would be that the clinical care team could wear RFID tags and flag when they're coming in and out of the room so that the caregivers have a sense of who's been there, when, and they could talk to certain people to understand what's been happening. The other problem that we noticed was the tracking of information. This is a nice quote of what happens. A patient talked about, most of the time I scrawled it on the back of some pamphlets that came out of a box of dressings because I didn't have any paper. In this case, they're talking about trying to keep track of when they're having certain symptoms, which their care team asked them about. The patient says they did have a whiteboard in my room, so I could keep track of some of it there, but some of it was embarrassing, and I didn't want it available to be read by anyone who walked in the room. So again, some challenges with how do we help people keep track of information, even when we're asking them for that information later. Another challenge was communicating. And this is a nice result of a co-design session with caregivers of pediatric patients. And they talked about the burden of repeating the same information. Anyone who's ever been to probably even a doctor's office as well as a hospital has experienced, you get asked over and again, what are your allergies? What's your medical history? And it was less that the caregivers were frustrated by being asked the same thing over and over again. It was more of a safety concern. They were worried that they'd forget to retell something important because they would remember telling someone, but they wouldn't be sure if they told everyone everything. Did they tell the right person the right thing at the right time? So they envisioned more of a summary, child's website, as they called it, to make sure those things are available so that they could check and make sure that they were in the system and visible to people. That they had a way to convey personal things too. I like a lot of our clinician participants were interested in this one of what scares me. They thought that would be particularly valuable information to have, not just for a pediatric population, but for even adult population, to be able to understand what scares people and help address it could be really important in the care process. And that was their desire to provide personal information. So how can hospitalized patients get support for receiving, tracking, and communicating information like we saw in these designs that people made and like we observed and heard about in our interviews and observations? A lot of people say, well, the solution is really inpatient portals. And certainly inpatient portals weren't very common when my husband John was in the hospital, although actually I was able to log in there and sometimes get results on the inpatient portal before some of the doctors that came in to see my husband. But by and large, these inpatient portals are not used very much. And a lot of studies has pointed to a lot of challenges with them, both, poor usability, not clear that they were designed necessarily with the patients in mind, rather just porting existing or similar to existing clinician-facing tools and making them visible to patients. So that continues to be a challenge. But what we did was we embarked on a low fidelity prototyping exercise where we created these things called feature cards, where we had different categories of kinds of features we heard about people wanting from the co-design sessions and from our interviews and observations, and kind of giving them a mock-up of an iPad and letting them pull the features that they liked from this notebook and designing their own app. By the way, this was incredibly popular with the pediatric population. They loved the idea of designing their own app to monitor their health information. So this is kind of what some of these feature cards looked like. We had a variety of them, things like making clear what the discharge goals are or their progress towards the discharge goals, some common kinds of things that are in inpatient portals, like seeing blood test results and so on. This is an interesting example of doctors' feelings about my health. That was something that participants said they wanted. They wanted to know how their clinicians felt about their health. But when we implemented it and showed it to them, universally, everyone hated this. They're like, I would never in a million years want to get a frowny face that my doctor has how my doctor feels about my health. So that just shows that it's important to feed back some of the suggestions and look deeply at how these things could actually work. Here's another example of some of the other kinds of things in our feature cards, focusing on communication, making it easy to request a second opinion, being able to reach doctors or nurses. Actually, wish I had this for all my collaborators, knowing who responds best to what mode of communication is an interesting idea. And different kinds of ways to let people know that your request is urgent versus just pushing a call button and having no sense of how important this information is. We had information that implemented some of the AHRQ safety suggestions, like having a safety checklist, hygiene and medicine checklists, information that would have helped my husband and I. What is the medicine? What should I look out for? Why am I taking this? All of those kinds of things is really providing information to the patient and their caregiver. But what we found in our studies was that a lot of these inpatient portals definitely provide some great information for people. And it even having that at the time would have certainly helped John and I. But we found a lot of the support that patients and their caregivers want is really missing in inpatient portals. And this is kind of a summary of 6 high-level features of helping people transition into the hospital, understanding what a hospital environment is like, how to navigate this hospital, how to maybe what to bring in from their home environment to help them in the hospital, different ways to help them ask questions and flag problems. But I'm going to focus or give a few examples from the adjusting schedules and getting updates, asking questions, and then doing a little bit deeper dive into preparing for discharge and home care. So adjusting schedules and updates. A great example here is a quote from a participant. I work while I'm in the hospital. So note that people aren't just patients, right? They often have to maintain a life. And sometimes patients are in the hospital for a long time and they need to be able to maybe work or do other aspects of their life. And they said, when you're in a hospital, there's just a continuous stream of people in and out. But if I had on my app where I could schedule some quiet time, that would be the absolutely single most useful thing in my current condition and what I do for a living. So again, having this sense of what's going to happen to them when, and have some ability to adjust their own life around what's happening in the hospital. In terms of asking questions and flagging problems, another participant said, I wonder if in the app you could type in a question and say, I just want to follow up with someone about this particular issue. So that way I'm not sitting face to face saying, I want a second opinion, right? Even as someone with a PhD in the field, it was really hard for me to second guess, to ask a question from the person in the room. There's been lots of studies that show sometimes people are more able to ask questions and deal with stressful situations if it's done electronically and not seeing someone face to face. So having that as an option, it could be one potential way to help. But now I'm going to go for a little more of a deep dive on the discharge and home care. And that's a known problem, right? I mean, one of the things that surveys look at is the readmissions rates and looking at the discharge process. A caregiver for a pediatric patient talks about it this way. They kept preparing me for the fact that this medication would have to be given a certain way until he starts eating, and then we can sprinkle it. Well, when I went to the pharmacy to get his medications, they didn't give me that version of it. They gave me one like a horse pill that I have to crush. And so they spent this time, so much time preparing me for one thing, and then I got a completely different version of the medication. I kind of wish I could have gotten the medication maybe a couple of days before discharge, so I could have done them in the hospital, like with the nurses, just so I would have had a better idea of that, because that first night, it took me about 2 hours to do his medications. I think this illustrates a real problem here in the way hospital care works, is that most of the time that someone is in the hospital, it's all the hospital managing their care, all their information, all their their medications, and so on. And yet when they're discharged, that all has to shift to be self-managed or family managed. And yet very little time is spent preparing for that discharge. There's tons of work looking at that discharge process and trying to make it work easier. But oftentimes it's rushed. And there's a gap between when people are discharged and when they're able to care for themselves. We see it as needing knowledge, resources, as well as self-efficacy, this kind of confidence that you can do it yourself. And we propose that an alternative way to think about that is to really try to slowly increase that over time while people are in the hospital, really helping people increase their knowledge, increase the resources they have at their hand because they're in a hospital environment, and gaining some self-confidence and self-efficacy to be able to care for themselves at home. So for example, a pediatric patient says, I have to have no fears. I have to have a good diet. I need to be able to take big pills before I can actually go home, so I don't have to have the IV anymore. So I think it's important to have goals so they, providers, can make sure everything is okay before you go home. So here, even a young child, we had participants as young as 7 who were all incredibly well informed about their care and very active in these exercises, understand a lot of these issues. And here they're talking about goals. So we need more support in patient portals for the variety of kinds of activities that patients need support with. And it has implications for design as well. We have a need to highlight patient-centered goals and preferences, a way to provide dynamic information about events as they're happening. And I'm not going to talk about this much, but we also discovered that a lot of people in the hospital are what we would call situationally impaired. Maybe they have IVs in their arms, they maybe patches on their eyes. They're not normally visually impaired, but they are in the hospital, and we don't often have ways to help these people. I'm going to talk a little bit more about highlighting patient-centered goals and preferences and what we did along these lines. So realizing that patients do have many goals for their hospital stay. Sometimes those goals are prescribed by the providers, like they need to be able to drink 5 cups of water per day or walk up and down the hallway 3 times. But patients sometimes have their own goals too, for having a good relationship with their providers, learning how to take their medication. But really, most of the time in the hospital environment, the patient goals are prescriptive. It's the clinical care team that are telling the patient what they need to do and what their goals should be. And the patient goals are not well documented. Obviously, there's more of a push for this with the latest policy recommendations, but in general, it's not very well supported. So oftentimes the clinical care team doesn't even know what the patient goals are. They aren't as visible in the electronic health record. So what we did was designed with patients, actually in this case with pediatric patients, on their goals and how to make these visible to both themselves and their clinical care team. So they wanted to be able to see a difference between their own goals and, or actually their own goals and their clinical care team goals, and be able to add their own goal and edit goals and see their progress towards these goals, like being able to drink 3 out of the 5 cups of water, walking down the hallway twice instead of 3 times. So we wanted to be able to have patients share their own goals and preferences, document the provider's goals for patients, because remember, these often are just verbally given and not very visible, and encourage discussion around these shared goals or conflicting goals, because oftentimes, well, sometimes at least, the patient and the caregiver and the care team might not all be in agreement on some of these goals. So what we did was we developed what we call a technology probe. So a kind of a minimally viable prototype that could be used in the hospital setting. And we deployed it with 13 families, patients as young as 7 years old to 20, because children's hospitals sometimes have up to 20-year-olds. And 4 different clinicians agreed to be a part of this study. And we had people use this, we call Plan and Talk, this technology probe, for at least 2 days while they were in hospital. Now, the way this system works is we set up a component that at the top, it describes a little bit about the person, what some summary of the goals, both the care team's goals and the patient's goals, and be able to see what the care team wants the patient to be able to do along in this time frame, right? Some things about when they're in the hospital, when they go home, and then someday. Note here that the patient can indicate some of their own goals, like someday they want to be able to go to Europe. And understanding that might be an important part of the care team's goals and the way that they take care of and treat that patient. There's also a component that's a talk component, discussing things that there might be conflicts about. So they can flag what they want to talk about, and it becomes visible to the care team and to the patient and their caregiver as well, to help discuss the things they want to talk about, as well as say the things that they perceive are going well. So some examples from this technology probe deployment. One participant or one clinician saw one of the patient's goals was to celebrate his birthday. That helped the clinician make sense that the patient was upset and hard to communicate with because the patient had to miss his birthday. So in some sense, this just making this visible to the clinical care team helped create some empathy and understanding around challenges that they were having in interacting with the patient. Here, a patient shared that they had a goal to draw cartoons, creating a way to connect with clinicians and drawing the patient into care discussions, even interrupting to give feedback. So another way to connect people with each other and help them understand each other. Here we had a situation where there was a conflicting goal. The patient's main goal was to remove her feeding tube, but that wasn't feasible medically. But since the clinician now knew that that was the patient's main goal, the clinician grounded her communication to the pediatric patient to explain why the feeding tube was necessary right now, and also drew connections to other goals that the patient set and explained why the feeding tube was needed to have some of the other patient's goals met, like gain weight consistently and increase heart rate to normal range. So it gave them some way to talk about these conflicts and make them explicit. And this was a very positive interaction in this particular example. So now let's come back to John's story. What would have happened if we had had some of these resources? If we'd had a better way to receive the information, keep track of what was happening, maybe to help support the transition of care, and to communicate with the care team maybe using something like an iPad app, but certainly having more functionality than was available to us at the time and is currently available largely too, to help us understand what this drug was, who was giving it to us, what the possible contraindications were. Having, when this drug is ordered, having it appear to us so we could potentially prepare for the clinical interaction and understand more about the drug in time to have a good interaction. So maybe it would have helped us communicate about the information that was available from the urgent care center and have a conversation and prevent John's crashing that happened later. So in the end, our goal is to create a new kind of advanced class of patient portals and systems, socio-technical systems that are really helpful for patients during their hospital stay and meet their needs so that they can truly engage in their care. So I want to acknowledge and thank my whole team, as well as the hundreds of children and adults and clinicians who all participated in our study and in these hospitals and the funding agency. And here's a sampling of some of the papers for some of our research. So now I would welcome questions. Thank you for having me.
And for questions, please feel free to raise your hands or put them in the chat. Wanda, if you want to facilitate the questions, that's totally fine. So feel free to do that.
Great. So first looks like Lin Ying.
Hi, Dr. Pratt. Thank you so much for a great presentation. Your work is really important and it's very interesting. And from a patient perspective, I would love to have your app installed at our NYP system tomorrow so that next time when I go to our hospital, I can have this tool that helps facilitate communication between me and my care providers. But at the same time, I think we're all aware in this community that there's physicians, they have heavy documentation burden, they're burned out. So I wonder if you have done any studies with the provider team about this tool that you created, like what's their perspective on using this tool in the care setting? And how much of that, for example, how much of that information in this tool will be entered by care providers in addition to what they may need to enter into the EHR system? And whether there's an opportunity for us to redisplay some of the things that are already in the EHR in this tool so that it can help the communication, but do not increase the documentation burden on the provider side. Thank you.
Yeah, absolutely. And that is a great question and a really important problem too, right? It isn't, clinicians are leaving the field in droves and they are burned out and struggling. In our study, note one that we designed, we focus on the design side and not the deployment, other than the few technology probes that we developed. But we also included clinicians in our co-design sessions. We actually had some sessions that were separate. The clinicians were separate from the patients and caregivers because we found sometimes the clinicians could dominate the conversation and we didn't want that. But we did some later sessions where we had them in different rooms, but then brought them together to share designs so that patients could see and help understand more of what clinicians' challenges were, and so that the clinicians could see some of what the patients' challenges were. And some of the things that the patients developed, the clinicians were very excited about too. So for example, the one dock away, physicians and nurses expressed frustration sometimes that they would go to a patient's room while they're on rounds or to check in with them, and they were gone. They were getting an x-ray or something, And there was no way for them to know that the patient wasn't there either. So in some sense, having that extra scheduling information the clinicians found that that could be helpful for them as well in planning things. I do think more work needs to be done on how we can make some of this information, make the burden on the clinicians adding the information lighter, so that they have time to do things like look at the important information about the personal goals of the patient and their own situation, because that's an important part of care too. But if they're overburdened with documentation, they don't have the time for that. So I agree that's an important part. And there are lots of people working on things from automatic note writing to medical scribes, all kinds of solutions along those lines. That is not as much of what I focused on, but I do think it's an important piece before anything can be implemented.
Thank you so much for your great answer. Thank you very much.
Hi, Dr. Pratt. Good to see you again. My question is really on the design side, and I think the response you just gave really focused in on this human-centered design and this co-design, this participatory design aspect. And I'm wondering, as a lot of us, especially doctoral students, are working on integrating machine learning methods and AI into these tools, how can we kind of either adapt this human-centered design paradigm or move more towards a human-centered AI paradigm? What would that look like to really think about kind of the capabilities and limitations of AI alongside the needs of human users that have different stakeholders like the patients and providers, and leveraging the AI but not writing over the human needs and things like that?
Yeah, great question. I mean, obviously there's a big push for more AI in medicine, which comes with maybe some potentially huge advantages, potentially reducing the documentation burden for clinicians, but also raises some other questions from a patient and safety perspective, and also from my role as the Associate Dean for Inclusion, Diversity, Equity, Access, and Sovereignty of is your training data really representing a diverse array of people? Have you consulted with them? So certainly the human-centered design part of me says you need to talk with and include the patients and their caregivers in the process of one, making sure that you're having a diverse array of stakeholders that are being consulted and not just the easiest people to get a hold of and bring in. It can be challenging to reach a variety of people, and sometimes you need to go where they are to get that information. I know Rita has done some great work with communities, and that's an excellent way to go as well. So I think just following some of those human-centered approaches and making sure that systems aren't just implemented without consulting with, collaborating with the patients and their caregivers too. Kayla.
Hi, Dr. Pratt. Thank you so much. This was really interesting. I'm curious kind of in the juxtaposition of patient priorities and care team priorities. I think it's really interesting to have them kind of side by side, and I'm curious what has kind of come up in terms of the language and ways that patients and caregivers might describe a goal similarly, a goal that might be similar in complete different language, like wanting to go to their kid's birthday party and wanting to like whatever the actual technical goal there might be, and how you see kind of language and descriptive differences playing a role in putting those goals next to each other.
Yeah, that's a great point, and it points out what a hard problem it really is. I mean, we presented a fairly simplistic solution, but there are a lot of nuances to that, right? In terms of clinicians often use specific medical terminology, which I understand some of, but not all of. What is an AV block? What does that mean? That can be challenging to translate that information. There's a lot of great work that others are doing. Excuse me, to address that problem too. I think it also brings up cultural issues and cultural competencies in the clinical care team. Because what it means to attend a birthday party for someone in one culture might have very important differences from somebody in a different culture. And the patients and caregiver might think that that's obvious to the clinical care team, and it might not be. So looking at ways to flag potential miscommunications and expansions of what that means, both translating the patient side and kind of their experience and cultural expectations, as well as translating from the clinical side too. It's a hard problem.
Yeah, and I think the fact that it's also cultural, that how imprecise that language can be is really interesting. Thank you.
Yeah.
All right, I think we're right about at time. So I want to say thank you so much again, Dr. Pratt, for this wonderful talk and the great discussion that we were able to have around this. This is such important work, and we really appreciate you sharing this with us. And personally, I'm excited to see where this goes next. Thanks to everybody who joined the seminar. We won't be having a seminar next week, but we will resume with 2 sessions the week after. So just stay tuned for an email about that. Thank you all so much for joining.